BRAF mutation. And I would like to welcome our second presenter, Dr. Caroline Robert. She's the head of dermatology at the Institute Gustave Hersey in Paris, France.
Thank you very much. I'm very happy to be here with you today to share this big news in our field. So I will present you the result of this phase 3 study, Efficacy of Trametinib, a potent and selective MEK inhibitor in progression-free survival and overall survival compared with chemotherapy in patients with BRAF V600E or mutant advanced or metastatic melanoma. You probably recognize this MAP kinase pathway. You know that it is activated in about 20% of all cancers, and in some cancers like melanoma, pancreatic, colorectal cancer, it's frequently activated in about 60% of the cases via RAS or RAF mutation. That makes of the MEK protein downstream from BRAF very attractive targets to treat these cancers. Trametinib is a very potent and selective inhibitor of this protein, MEK1 and 2, and it already had showed efficacy in phase 1 and 2 trial on patients with BRAF mutant melanoma. So this initiated this phase 3 study. More than 1,000 patients were screened for V600E or K mutation. Out of them, 322 were positive for the mutation, and they were randomized to receive 2-to-1, either trametinib, 2 milligrams per day, or chemotherapy. This patient could have received up to 1 line of previous treatment, so the chemotherapy could be dacarbazine or paclitaxel. The main objective was progression-free survival, and the patient who progressed on the chemotherapy arm could cross over to receive trametinib secondarily. Stratification factor, LDH, prior chemotherapy. Primary endpoint, as I said, PFS, and secondary endpoint, all the usual objective, overall survival, response rate, safety. Here is the demographics. You see that almost all the parameters are well balanced, except maybe the percentage of patients with stage 4 M1C disease, which was more elevated in the trametinib arm, 67 versus 58. We had very few patients with a history of brain mets, 3%. 30% with prior immunotherapy, 34% prior chemotherapy, and as expected, we had more patients with V600E, 87%, versus V600K mutant, only 13%. In terms of safety, these are the side effects that occurred in more than 15% of the patients. They were mostly grade 1 and 2, and they were affecting the skin, majoritarily rash, dermatitis acneiform, but came diarrhea, peripheral edema, fatigue, hypertension. The specific side effect that we knew can occur with MEK inhibitor, decreased ejection fraction, and ventricular dysfunction were occurring in 14 patients, 7%. Less than 1% were grade 3, and there were no grade 4. It was mostly asymptomatic, always reversible. We had 1 case of chorioretinopathy, grade 3, reversible. No reported case of squamous cell carcinoma or any hyperproliferative skin disorder. The severe side effects, very few of them. We had 12% patients with hypertension. It was always manageable, did not require any reduction of the dose. Here is the main results. This curve shows the PFS between the 2 arms, trametinib and chemotherapy-treated patient. And this shows you that there is a very significant difference in terms of PFS in these 2 populations of patients. We have a median PFS of 4.8 months in the trametinib versus 1.5 in the chemotherapy arm. Hazard ratio 0.45, meaning that there is a 55% reduction of risk of progression or death for the patient who received trametinib, with a very significant p-value. This shows you the response rate, confirmed response rate of 22% in the trametinib arm versus 8%. And here you see the waterfall curves showing the patient who had decreased their target lesion of more than 30%, which is 39% of the patient here versus 15%. And Last but not least, let me remind you that crossover was allowed. That, of course, can blend the results of overall survival, but even in spite of this crossover, we had actually 47% of the patients crossed over, so almost 50% of them, but in spite of that, we still have a difference in overall survival with 54 as a ratio of 0.54, meaning 46% decrease of risk of death with trametinib compared to chemotherapy. At 6 months, 81% of the patients are still alive versus 67% with the chemotherapy. So trametinib is the first in-class MEK inhibitor to show a statistically significant activity in PFS, response rate, and overall survival benefit in a randomized trial, and here in this population of BRAF mutant melanoma patients. The safety profile is very safe, very manageable, and we have no case of squamous cell carcinoma and very expected and rare specific toxicity. Thus, this phase 3 provides a really positive risk-benefit ratio of trametinib in patients with BRAF mutant melanoma and delivers an alternate treatment option for these patients. Thank you very much.